Good afternoon, everyone, or good morning, I suppose, depending on what time zone you're in. Welcome to the webinar. My name is Lucas Brand. I am the Strategic Director for the ACS National Prostate Cancer Roundtable, and I'll be your host for today's discussion, which we're calling Recent Advances in the Clinical Management of Metastatic Prostate Cancer. Over the last several years, we've seen a real impressive set of advances in genetics, genomics, imaging, targeted therapies, and the way we use different therapeutics together in combination. And these advances have really transformed how advanced and metastatic prostate cancer is managed in the clinic. With such a groundswell of new technologies, making sure that we're using them effectively as possible is of really of paramount importance. And it has the potential to improve patients' outcomes and their lives. So today we're going to be exploring how clinicians can integrate these new advances, genetic and genomic insights, into patient care and leveraging newly approved therapies and utilizing advanced imaging technologies such as PSMA-PET to guide treatment decisions. This discussion is going to highlight how this cutting-edge science is helping to shape the future of prostate cancer care. So before we get started, I just want to take a moment to sincerely thank our sponsors, Pfizer and Bayer, for the generous support. This partnership plays a really vital role in making today's webinar and really the rest of the work of the roundtable possible. So thank you to these institutions for their commitment to advancing the initiatives of the roundtable and prostate cancer awareness in general. Few ground rules for today. So ACS is a nonpartisan organization. We believe that everyone should have a fair and just opportunity to prevent, detect, treat, and survive cancer. So we therefore are asking that we avoid any kind of partisan topics and opinions during the discussion today. We have our rules for engagement, which you can read on our website. Basically, just to distill this down, the rules for engagement basically state that we would like everybody to treat each other with kindness and respect, realizing that we are all here for the same reason, which is to improve the lives of patients and understand how to better manage prostate cancer in the clinic for everyone. So that's the gist of it, and that's what we're asking everyone to do in our discussion today. Finally, this webinar is being recorded. It will be posted on our website and available for viewing after the fact. So please be mindful of the conversation and respectful of others' privacy. If discussing a clinical example or a patient case, make sure that we are not using any identifying information and keeping their confidentiality paramount. Some housekeeping items. We're asking everyone to please remain with camera off during the webinar and remain muted. If you have questions, please feel free to type them into the chat. We will have a Q&A session at the end of the webinar where we can answer any questions. And again, just please remain courteous and abide by those rules of engagement that I mentioned earlier. Our objectives for today, as I mentioned earlier, we have all of these new technologies and advances to discuss. So we want to introduce everybody to those and discuss how they can be appropriately leveraged in the clinic, including how genetics and genomics can be applied in this disease stage to improve patient outcomes, talking about some of the advances in new therapeutics and the way those therapeutics are combined for late-stage prostate cancer patients. And then finally, new imaging, theranostic, and other types of radiology modalities are changing how we manage this stage of disease for prostate cancer patients. This is your ACS National Prostate Cancer Roundtable team. Our Vice President of the National Roundtables and Coalitions Business Unit is Sarah Schaefer. You have me, yours truly, as the Strategic Director, and our Program Manager, Naya Green, is our producer for the webinar today, and she's working from behind the scenes. We have a pre-webinar poll for you to take. These are some knowledge questions that will help us to evaluate the effectiveness of our discussion today. So I'd ask you to take just a couple minutes. I will go off camera while you're taking this quiz. Fill it out to the best of your ability, and we'll do this again at the end of the webinar to measure how well we did at instructing you about these things. So feel free to take a few minutes here. All right, so I know that went by quickly, but thank you for participating in this pre-poll. We'll circle back to this at the end, and you'll have another chance to address these questions after we've had some time to discuss these topics. Moving ahead, our speakers for today. The first speaker that you'll hear from is Dr. William O. He is our chair of the National Prostate Cancer Roundtable here at the ACS, and he is also the director of precision medicine and a professor of medicine in the Department of Clinical Oncology at Yale School of Medicine. He also serves as the service line medical director of Smilow Cancer Hospital at Greenwich Hospital, and he'll be taking us through our slide deck presentation today, so you'll hear from him first. After Dr. O finishes up his part of the presentation, we'll bring in a panel of experts to discuss some cases with him and respond to any questions that you all might put into the chat. So those folks who you'll be hearing from later in the hour are Dr. Evan Yu. He is the section head of medical oncology in the clinical research division at Fred Hutch Cancer Center. He also serves as the medical director for clinical research at Fred Hutch and the University of Washington's Seattle Children's Cancer Consortium. And he's a professor at the University of Washington and Fred Hutch Cancer Center. Dr. Joshua Lang is the second member of our expert panel. He's a professor of medicine and director of the University of Wisconsin's Carboni Cancer Center. He works on the circulating biomarker core and liquid biospecimen team, is the co-leader of its tumor microenvironment program, and the clinical co-chair of its precision medicine molecular tumor board. And then finally, rounding out our expert panel is Dr. Bridget Koontz. Dr. Koontz is a board-certified radiation oncologist and serves as chair and medical director for the Department of Radiation Oncology at Advent Health Cancer Institute. Just a reminder that we'll have time for questions at the end of today's webinar, so please continue to put those in the Q&A box so we can discuss them. Last thing from me before I turn it over to Dr. O, we have our disclosures slide, which I'm just going to pop up here briefly, and then I am going to turn it over to Dr. O.
Thank you, Lucas. I'm going to go ahead and share my slides. Please let me know if you can see them in the correct orientation. Hold on, I'm going to flip it. Is that correct? Okay, Well, thank you all for joining us. We have a really amazing panel today, so I do want to get to some conversations, but what we thought we would do is really review some of the recent advances and get some of the expert opinions. So I may call on them to kind of chime in as I move through this brief presentation. So just as a reminder, everyone on this call knows about the burden of prostate cancer. These are relatively recent statistics that show, in fact, that it continues to be the leading cause of cancer in men in the United States and the second leading cause of cancer death. And there are some concerning statistics because these incidence rates and also rates of metastatic disease are actually rising. They're not falling. And you can see this. There's actually an article in the New York Times yesterday highlighting this updated data from the ACS that shows that in men, you can see this very sharp rise after this drop with the advent of PSA testing in the 1990s. You can see there was a drop, and then suddenly there's a rise over the past decade in terms of incidence. You actually see a similar rise in breast cancer incidence. But I'd say in some ways, even more concerning, what we see on this paper from a few years ago is two things. One is we see a rise in the rate of distant metastasis, which was also the subject of the paper that was covered in the New York Times yesterday. You see distant metastases are the kinds that can lead to death and suffering from prostate cancer. And you see this, again, roughly same time period from about a decade ago, you see this continued rise in the rate of distant metastasis. You also see this continued disparity. These are two of the take-home messages about the epidemiology, which is that the incidence of advanced disease is rising and the disparity between Black men in these green dots and all of the races below are unfortunately persisting. Prostate cancer is one of those diseases where we think of it in terms of the different disease states model. And basically, men who are diagnosed early have clinically localized prostate cancer, and they could be cured, for example, with surgery or radiation. Sometimes they're offered active surveillance. But a subset of these men will actually not be cured, potentially because the cancer was not caught in time, and they may proceed through this rising PSA state and then subsequently develop what's called hormone-sensitive prostate cancer and then castration-resistant prostate cancer. And it's really this last state which is considered the potentially lethal state of prostate cancer. And for many years, we knew that because this is occurring in older men, there is a competing risk. That is, men may die of other causes versus prostate cancer. But as men have gotten healthier and are living longer, as cardiologists are better at preventing other causes of death, this risk of prostate cancer death may be starting to both plateau and even start to rise. So what is our treatment landscape in 2025? It's much better than it used to be. I started in this field over 2.5 decades ago, and the good news is there's a lot of new treatments, and you can see them color-coded here. We're going to talk about a few of these in turn today, but the problem is that none of them are curative. Certainly when patients develop metastatic disease, we can keep the cancer in remission for a long time, but we cannot cure them. And we're going to come back to some of these. I'm not going to spend a lot of time on this particular cartoon, but we'll come back to some of these new treatments, particularly the ones that are very exciting and may actually move the field forward, has moved the field forward as we think of new options. I'm just going to start with an area that we are all very aware of, which is androgen receptor pathway inhibitors, so-called ARPIs. What this really means is that in the 1940s, starting with this urologist named Charles Huggins, it was identified that prostate cancer is stimulated by testosterone. And we have to understand how profound a discovery this really was. To us now, it seems really obvious, but at the time, men with metastatic prostate cancer had no real options. And Dr. Huggins and his colleagues were the first to understand that this cancer is driven by androgen. And so all the treatments that were developed initially, including estrogens like DES, LHRH agonists, and subsequently antagonists, all block the production of testosterone. Of course, orchiectomy does as well. And orchiectomy is a treatment we don't do a lot in the United States, but clearly works as a way of depleting testosterone because the majority of testosterone is made in the testicles. But there are some advances, including the so-called GnRH or LHRH antagonists like relugolix or dagarelix. We can talk a little bit about that and maybe in the Q&A. But one of the things that we've learned in the last few years is that combination therapy can target what we consider to be a heterogeneous tumor in metastatic hormone-sensitive prostate cancer. In other words, if you look at this cartoon, you can see that typically metastatic prostate cancer cells are a mixture of different kinds of cells, some that are sensitive and some that are not sensitive to androgen deprivation therapy. So traditionally, when we would give men androgen deprivation therapy, going back many decades now, we might select for more resistant cells. And what we've learned in the last few years is that giving combinations of cells, of therapies, would block both androgen sensitive but also androgen insensitive cells, and perhaps improve survival. And that's exactly what we found with a combination of different treatments, androgen deprivation therapy plus abiraterone, or these blockers, apalutamide, darolutamide, enzalutamide, and also chemotherapy. So without going into this in great length, what we know is that over the last few years, there have been now 11 randomized trials demonstrating significant survival benefit for combination therapy in MHSPC. You can see here, it goes all the way back now almost 20 years, but most recently in 2022, we saw the Aranote study. So what it really means is that if you give a double therapy, that is ADT plus one of these ARPs that I showed earlier, the hormone treatments, you have an improvement in survival that ranges from 20 to almost 40%. And if you give triplet therapy, that is add chemotherapy versus chemotherapy plus an ARP, you get a very similar significant benefit. So this really has transformed in the last decade how we treat men who walk in the door with MHSPC. You should either get a doublet or a triplet based on this data, unless there's an absolute contraindication to therapy. So I like to, show a cartoon like this to kind of point out how important it is. It used to be for many years ADT alone or ADT plus docetaxel was the standard of care, and now these triplet therapies that are noted here have become a standard of care. But these two options should really not be considered an option for most of these patients. So I'm going to just pause here and ask Dr. Yu to join me and just comment on this data, Evan. What is this meant, and how does it influence your practice?
Yeah, I think it's really important data. I think the key thing to recognize is that hitting the androgen receptor, which is the tried and true target for prostate cancer, which is the testosterone axis binding to the androgen receptor protein on the cancer cells, that hitting it harder clearly leads to additional survival benefits. So doublets are kind of my base. Now, for patients that have much higher risk characteristics, so let's say they present de novo, or what we call synchronous metastatic disease, meaning it wasn't found to be localized in the prostate and the patient had surgery or radiation years ago and then relapsed later, those patients have a better prognosis. But de novo or synchronous means when they were diagnosed with prostate cancer, they already had metastatic disease. Those patients, unfortunately, have a worse prognosis. The disease is generally felt to be more aggressive. For that de novo patient population, especially if they have higher volumes of disease, those patients benefit from the triplet therapy, where you're hitting it with your standard hormonal testosterone lowering therapies, the shots, plus the pills, and then also adding 6 doses of chemotherapy on top. So this is kind of where we're at now, and you're probably going to talk about this later, but there are some new things that are coming down the road. We haven't even seen all the data yet, but some of it's coming soon that may change what we do in the future and further add advances.
Thank you, Evan. That's really helpful context, and we will get to that when we discuss some of the cases. All right. So shifting to this next phase, one of the questions is what is the era of precision medicine? And this is a slide that tells us that, in fact, molecularly driven treatment decisions are becoming much more common. This is a study from last year that showed that all of these are so-called targeted therapies. You can see that the FDA drug labels for each of these drugs is specific for these genes, specific for genes that only a patient with that particular gene will respond to the treatment. And if you look at this was not 2017 to 2022, in that 5-year period, the number of patients who are candidates for molecularly driven targeted therapy went from 8.9% to 31.6%. So if you're an optimist, you'd say, wow, that's a really rapid change. If you're a pessimist, you might say, that 2/3 of patients still don't have a targeted therapy option. Prostate cancer is also a disease where targeted therapies do work. We already talked about androgen receptor. That is a type of targeted therapy, but the vast majority of cancers make androgen receptor. But the most important gene alterations in metastatic prostate cancer are so-called DDR mutations, or DNA damage repair mutations, also known as HRR mutations. And just a few numbers here to remember, and I'm going to ask Dr. Lang to talk about this more in a minute, but about a quarter of all patients with metastatic castration-resistant, that's hormone-resistant prostate cancers, will actually have some form of a DDR mutation. And about half of these are germline, meaning they inherited from their mother or father, and the other half are somatic, meaning that they did not inherit the mutation, but they somehow acquired it during their lifetimes. And of those 23%, you can see about half of them are BRCA2. So we'll talk about why this is important and why testing is particularly important, because this is some data from last year that showed that in the United States, over 60% of patients with mCRPC never get tested for these mutations, either somatic or germline. So this is really a very concerning number. And you can see that it kind of plateaued during the pandemic, but instead of going up, it continued to plateau. So this is an area that I think we really need to focus on because of all of these valuable PARP inhibitors. So Josh, can I ask you to comment a little bit about targeted therapies based on DDR mutations?
Absolutely. And thank you, William. This is such a vital area in the treatment of men with advanced prostate cancer, especially because we know that these are actual mutations and we have therapies that are highly effective. There are side effects to these therapies, but we've found from the clinical trials that if we manage those side effects, watch them closely, do appropriate dose reductions, that these are treatments that men can use for years of time. I think it's even more important because these are the patients who also develop resistance to hormone therapies faster than nearly anyone else. When we talk about the use of combination therapy, the doublets and the triplets for men with newly diagnosed metastatic prostate cancer, well, if those patients also have an HRR or DDR mutation, the terms are roughly synonymous, or some other high-risk genomic mutations, we know that those men can develop castration-resistant prostate cancer in less than 2 years. And that can be a life-threatening event in less than 3. So it's so critical that we're doing appropriate genetic testing to identify the men who would benefit from these new targeted therapies. It really is, I think, one of the most important things that we can do for men with metastatic castration-resistant prostate cancer is ensure that all men have had tumor testing and ideally germline testing as well. And we're going to talk a little bit about this later too, but how that also rolls into cascade testing. Because if there's a gentleman who has a BRCA2 mutation, it's absolutely critical that his family, his children are tested as well to see if they're at risk for other types of cancers that, again, could also be intervened upon.
Yeah, thank you for that. Yeah, it's so important. I think we've saved a lot of patients' families' lives by identifying a genetic risk and then having that family member, a daughter or a brother, go and get tested themselves and actually found an increased risk. Okay, we're going to shift to another very exciting area. Lucas had pointed out that we really have transformed imaging, and I'm going to ask Dr. Koontz to talk in a minute about our imaging and how PSMA-PET has transformed it. But seeing the cancer is very, very important, but then using the same imaging approach and delivering a toxic payload, in this case, something called lutetium-177, is really an amazing new advance. This is called theranostics or radiopharmaceuticals or radioligand therapies. You'll see a lot of different names. But you can see here, basically, what this particle does is the radioactive payload, Lu-177, is a toxic beta particle. And what it does, though, is instead of just going throughout the whole body, it only attaches to a cell that makes PSMA. And PSMA stands for prostate-specific membrane antigen. So in the body, it really only goes to where the cancer cells are. There is some uptake in other organs like the salivary glands. So sometimes patients who get this will get a dry mouth. But for the most part, it's highly targeted, specialized therapy. And you can see here, these are what these images look like. And you can see in this case, you see this kind of much greater clarity that is PSMA positive and which you can target with this. Unfortunately, not 100% of these patients make PSMA only. You can see that when you overlap these, there are some cells that don't make PSMA. And unfortunately, this treatment will only work if it targets 100% of the cancer cells. So we'll talk a little bit about that. And some cancers make FDG, which is glucose uptake, but they do not actually have PSMA, and those are sometimes the most aggressive types of cancers. So we'll hear in a minute a little bit about how to differentiate these. But based on that trial that was published in the New England Journal called the Vision trial, now almost 4 years ago, we can see that progression-free survival and overall survival was significantly better with the treatment arm, LU177 PSMA, compared to standard of care alone. And you can see, if you look at overall survival, the hazard ratio is 0.62. That's almost a 40% improvement in overall survival. And I should point out, all of these men had already received an ARPI, had already received ADT, and also had received chemotherapy. So these were men who really were fairly far along in terms of their treatment course, did not have a lot of other therapeutic options. And if you look at secondary endpoints like PSA declines, these are, of course, we may rely a little too much on PSA, but when men like to see their PSAs go down, and you can see that there was a significantly increased PSA response in the group that received LU177. So Bridget, I'd like you to comment a little bit about both PSMA as an imaging test and how it's changed your practice as a radiation oncologist, but also this theranostic approach.
Yeah. So I have to say PSMA imaging has, I mean, it's changed all of our lives in terms of how we care for prostate cancer patients. As many in the audience know, PSMA diagnostic testing is now widely utilized both from at all levels of sort of that cancer journey, from high risk diagnosis and then recurrent stage and in the metastatic patients to understand treatment progression. You know, one of the most important factors to think about is prior to PET for prostate cancer, there was a category of men whose PSA would rise after treatment, but standard testing such as bone scan or CAT scan wasn't able to diagnose. And in those men, there was, long conversations about when do we start hormone therapy? Do we wait? From a radiation perspective, is there a target that we can treat with radiation or not? PSMA-PET is very sensitive for recurrence, and in fact, a PSA of 0.2, half of the time, patients will actually have a finding on PSMA-PET. So that now, the conversation about what do we do next, we often have a better understanding of whether a patient does have locally recurrent or metastatic disease. Therapy, again, the PSMA therapy is tagged, that's the word theranostics came from. So first we had the diagnostic agent, now we have a therapeutic agent. And it has also really changed how we treat metastatic prostate cancer, because as you know, we now have an extra treatment option in our armamentarium. I often describe this treatment as a different type of chemotherapy. So we're using it for metastatic prostate cancer. We're using it as you showed, the first study, Vision, was for patients who had already had chemotherapy and had progression. And we now also, with PSMA-4 and some other studies, are looking at it in the metastatic castration refractory prior to chemotherapy option. So it's slowly moving up as an option as we go through our trials. And it just provides one more thing that we have as an option to help patients, live their best life.
Thank you, Bridget. And we will talk more about kind of where it fits in the pathway. I showed that very complicated therapeutic slide. It's getting crowded, which is great. We think some of these treatments might move earlier and earlier in the patient's disease course. Unfortunately, they're not curative as yet, but hopefully one day these treatments will become curative. So I'm going to talk a little bit about immunotherapy, and I'm going to ask Dr. Lang and Dr. Yu to comment on these kinds of targeted immunotherapies. Bispecifics are another way of delivering immune therapy to cancer cells, and there's a whole list, a partial list here of drug companies developing targeted therapies. Can you maybe Josh, you start and talk about why immunotherapies like pembrolizumab and the more standard types of treatments that work in melanoma and lung cancer, why they don't seem to work in prostate cancer, and what's the difference? Are these kinds of bispecific antibodies going to work in a way that immunotherapy has not yet?
Thank you, William. Well, I'm really excited that we actually are at a time now when we can expand our concept of what immunotherapy is. For so many years, it really has been checkpoint inhibitors that target CTLA-4 or PD-L1. And unfortunately, in prostate cancer, except for patients who have specific genomic mutations, including MSI high prostate cancer or those very rare POL mutations, those are the folks that can benefit from checkpoint inhibitors. Otherwise, we really just have not seen the larger benefits that we really hoped for when we go back many years when those phase 3 trials were designed. So now we have these exciting new therapies where really coming back to the biology that there's something different about prostate cancer. It really prevents T cells from entering that microenvironment, those places where the cancer is growing and causing our patients such harm and suffering. So these new types of bispecific T cell engagers are using basically an extra antibody that's connected to it to grab T cells, but also bring them specifically to the cancer cells. Now, those cancer cells still have to express that protein target. But again, I think that's where there's a lot of hope for these agents as well. We learned this lesson from the VISION trial, the PSMA radioligand therapy. Again, PSMA is what that agent is targeting. So can we now do that? But rather than a radiation payload, can we actually try to bring the immune cells to directly attack the cancer? So you've got a great list here of agents that are in phase 2 and phase 3 trials against new targets. So also going beyond PSMA. And I think that's where we have the PSMA therapies and the PSMA bites, and then others that target other cancers, prostate cancers that may not express PSMA.
Right. So TAA stands for tumor-associated antigens. PSMA is the most promising one, as we talked about with regard to the radioligand, the theranostics, but there are many other targets that may be specific for prostate cancer. So it's a very exciting area. And I just I put these slides probably not in the best order, but Evan, maybe because this still happens to be important for a very small percentage, could you just talk about the patients who might be a candidate for pembrolizumab that Josh just referred to?
Yeah, I think the patient population that has the greatest likelihood of response to pembrolizumab or these PD-1, PD-L1 checkpoint inhibitors, what they essentially do is they take the brake off the immune system and allow it to be hyperactivated. Well, prostate cancer tends to be a cancer that doesn't have a lot of immune cells hanging around. It has what we call an immune exclusive microenvironment that kind of keeps those cells out. There is this patient population here that the slide refers to that actually does have a lot of immune cells in the microenvironment. So taking the brake off of that immune system there and with those cells that are present in the tumor makes a lot of sense. And this patient population are those patients that have one of three criteria, oftentimes all three criteria, which is first, they have a mutation in a gene set called mismatch repair genes. These are genes that are involved where their protein is involved in repairing DNA when there are there is what should I say? I'd say either damage or that there's an inappropriate insertion of DNA components, and it basically repairs that out. Now, when that happens, because that is involved in kind of checking the system, what ends up happening is you have widespread mutations throughout the genome. And those widespread mutations can help lead to cancers that have all kinds of abnormal protein production. Your immune system can recognize that abnormal protein production and rush to that tumor. Now, that is one hallmark characteristic of this small subset of patients, about 3 to 5%, with advanced metastatic castration-resistant prostate cancer. That can be what we call mismatch repair gene mutations. It can also lead to microsatellite instability, and it can lead to hypermutation, which one could argue that hypermutation is abnormal proteins is the most important characteristic that hasn't necessarily panned out in our clinical studies. But if you have what we call TMB, tumor mutational burden, high tumors, there is also an FDA approval for pembrolizumab. So for mismatch repair altered, microsatellite high, or tumor mutational burden high tumors, this is all stuff that you get when you do a next generation sequencing panel. When you have your tumor sequenced, this is part of the panel that comes back and gives a report on all of this. If you have any one of those components, you can be eligible for pembrolizumab, although it's more ideal to have a combination of these components rather than just one.
Thank you for that explanation. Really helpful. So let me just wrap up this piece, and I'm going to ask Dr. Koontz to also um, uh, uh, show her camera so that we can go right into the cases. But this is my summary. There's a lot going on here. The first thing is that everyone should consider for metastatic disease, hormone-sensitive prostate cancer, everyone should get at least ADT and either an ARPI with or without docetaxel. We can talk a little bit about who should get docetaxel. The sequencing of the treatments should be based on biomarkers, prior therapy, and clinical status. We listed several of these novel areas. We didn't talk a lot about chemo. We can talk about that further in the cases. And we did hint at and touch on some of these promising areas, what are called RLTs or radioligand therapies, bispecifics, and ADCs, which are antibody drug conjugates, which is kind of targeted chemotherapy. We'll talk a little bit about that as well. But I'm just going to end, this is my last slide, just to show you kind of what we talked about. In pink are the ARPIs, PARP inhibitors, about a quarter of patients. We didn't focus on radium, but we know that LU177 is actually moving earlier. I have to update my slides. These slides keep changing, so I realize that LU177 is listed kind of after chemo, but it's actually moved as Bridget pointed out before chemo. Pembrolizumab in that small percentage of patients. And all patients should get ADT as well as bone-targeted treatment. So I'm going to go straight into the cases with our three experts. This is an 82-year-old white male, presents with a prostate nodule on exam. He had PSA screening tests done until age 71, and at which point his PCP stopped. He has AFib, GERD, hyperlipidemia, and seasonal allergies, a little bit of nocturia, PSA 17. He's noted by his primary care doctor to have a firm nodule on his right side. His biopsy shows a Gleason 4+5 = 9. So let me start with you, Bridget. Should we stop PSA screening at the age of 71? What do you think? I know that's a loaded question, but what do you think?
Yeah, that definitely is a tough one, particularly with recent news and lots of discussion around former President Biden, et cetera. I think that the original recommendations around PSA screening were really meant from a place of concern about over testing. And I think what we've realized as clinicians is we are now starting to see patients who present with aggressive, either locally advanced or metastatic disease that really actually sound like stories from before PSA existed. The truth is somewhere in the middle. My personal take on this is that there are patients who it is appropriate to stop screening at age 70. Those who have a significant medical comorbidities, if you look at, we're terrible at predicting life expectancy, but someone who is expected to have a life expectancy of less than 10 years, it doesn't make sense to be doing PSA screening when the natural history of prostate cancer is usually at least 10 years. Those who have family histories, I think that's where we would probably continue PSA screening. And that leaves a lot of people in a gray zone. And I think it's an area of ongoing debate. I'd be curious about what colleagues here on this call think.
Let me show you what his MRI showed. It did show a nodule with extraprostatic extension, and his PSMA-PET did show multiple bone lesions. So Josh, what do you think? This happens to be President Biden. I know I wasn't supposed to, Josh, when we started, Lucas said, don't talk about anyone, but he is a public figure. Most of this is true. I didn't know his PSA. I didn't know his symptoms, but and I don't know what his PET scan is, obviously, but it does show something that we're all seeing more and more of. So Josh, what's your take on this as an oncologist?
Yeah, it's certainly a very challenging clinical situation. Unfortunately, the therapeutic options have completely changed in just the last short number of years. I think this is really where, as we step back and say, are there opportunities that were missed in screening? I think it's really, unfortunately, the data shows that the decline in screening has increased the rates of men presenting with advanced disease, including men under the age of 65 when screening is clearly indicated. And just as Dr. Koontz said, that as men get older, you have to weigh the benefits and the risks, especially with comorbid health conditions. And I think there's arguments to make that for men who are in their 70s and otherwise healthy with no other life-limiting issues, yeah, we should continue regular prostate screening. But this also relates to what we're seeing here in this particular scan of that men who go undiagnosed for a number of years, that the risk of the cancer changing and not only developing, but just metastasizing to multiple sites. These are exactly the patients you want to do biopsies on. You want to do genetic testing to understand what high-risk mutations are present and how does that change what we would recommend. And that comes back to the importance of doublet therapy. Again, still, a significant minority of men are not being offered doublet therapy for newly diagnosed metastatic disease, such as this situation here. And if there's other high-risk features, they need to be getting triplet therapy too. So that opportunity to bring in chemotherapy, which attacks the cancer from a very different direction, so to speak, than our hormonal-based therapies. And it gives us that better opportunity to hit the cancer harder earlier in a way that's going to lead to significant improvements in survival. And those are the big take-home lessons from all these clinical trials, is that using these therapies early is much more effective than using them later.
And would you give this patient doublet or triplet therapy? And why? Evan?
Yeah, that's a tough one. I mean, I think that I would probably give doublet therapy. There's no data that this patient has, really high volumes of disease on conventional imaging. We also have to take into account, risk-benefit ratio and the patient's overall fitness and what the patient and the family desire. So I would have a conversation, but I think if you think about, the definitive patient population where there's the most benefit, I think it's for patients who have definitive de novo high volume disease. And although he has what we would call de novo disease here, I'm not so sure it's high volume. Remember that the criteria for defining volume was using traditional bone scans and CT scans, not PSMA-PET. So we have to be careful not to over extrapolate. And we have to keep in mind the patient's overall fitness and quality of life, comorbidities, all these things. So I would lean towards doublet, but it would really depend upon, working with the patient, understanding the entire medical history and discussions with the patient and family, all of which I can't have in this situation.
None of us. Right. None of us.
Yeah.
Bridget, if there were 3 bone metastasis in an otherwise healthy 82-year-old man, would you offer radiation to his prostate and or the bone lesions?
Yeah, absolutely, I would. So you're referring to the Stampede data, which showed that for patients who had limited metastatic volume, radiating the prostate was able to improve survival with limited volume disease. And then, ongoing developing data that are suggestive that treating the oligometastatic bone metastases at the very least can delay progression. And I just want to emphasize again, Evan's point about not taking a PSMA-PET and using that to apply conventional imaging studies, studies that use conventional imaging to define MET. So in this particular patient example with that PET scan, actually, I'd love to get a bone scan and see how many of these are lighting up. Sometimes patients don't want to do that, but you could look and say how big they are. Can you see them on the CT? There's ways of analyzing, but while he certainly has a lot of bone lesions on PET, I don't really know quite yet, based on just this image, whether he also might be a candidate for prostate radiation.
Really, really important point. The data is older, so the field keeps moving. So how do we extrapolate 5 or 10-year-old data to what we're seeing now? Because it's clearly transformed. Okay, let's move to the second case. This is my patient, a 79-year-old Korean male with Gleason 9 prostate cancer. Previously had an radical prostatectomy. His PSA rose. He had retroperitoneal lymph nodes and a negative bone scan. So you can see it was a few years back. He started on ADT, but progressed within a year, had obstructive uropathy, requiring nephrostomy tubes. He was on ABI, but for a very short period of time, so pretty aggressive. And his family history was quite fascinating. He had 2 brothers with prostate cancer who died of it, and his son actually tested himself through a commercial, a consumer-facing lab, and actually had a pathogenic mutation in BRCA2. So Josh, how would you treat this patient?
So this is a great case, and I actually just saw somebody yesterday in my clinic in a very similar situation. So you have a germline, so inherited BRCA2 mutation. I'm sure the somatic testing is likely going to show that double hit of another BRCA2 mutation. And these are exactly the patients where we want to think about using PARP inhibitors. And probably I think the BRCA2 mutations also have not only are they the most common of those HRR mutations in prostate cancer, but also the ones that have the greatest benefit from PARP inhibitors. In our clearest data for men in this situation where he's been treated with abiraterone, but develops a very early resistance, again, also very common with HRR mutations, develop resistance to ADT and PARP and ARPIs. So this is also coming back to say our clearest data here is where single agent PARP inhibitors are FDA approved. So drugs like olaparib, I think, are very much indicated. It is a bigger debate in the field in terms of would we consider using a combination such as enzalutamide and talazoparib or abiraterone and niraparib, in part because those combination trials, for the most part, did not include patients who had progressed on a prior ARPI. There was a small subset of patients in the TALAPRO-2 trial, so talazoparib and enzalutamide, that had prior abiraterone, but that trial didn't have sufficient patients. It wasn't powered for that endpoint to say, is the combination better for these men than just doing talazoparib or a single agent PARP inhibitor? There's something called the Brackaway trial led by Dr. Maha Hussein, which suggests that there's evidence of synergy with a combination, but it's still kind of early days. So coming back to your question, I think this is a patient I would absolutely use a PARP inhibitor. Depending on comorbid conditions, this is where you also want to talk about, would we consider going with monotherapy with olaparib or consider a combination therapy with another ARPI and a PARP inhibitor?
A really excellent discussion and a little bit of a debate because he progressed so quickly on Abby. Are you just adding toxicity, for example, with Enza, or is it truly synergistic? And the Brockaway study, which we can refer people to review, suggests that there might be synergy, but not necessarily. Yes, Evan.
Yeah, so I just want to throw in my 2 cents on this case because I know that there's debate. Generally, I would do monotherapy with a PARP inhibitor, single agent PARP inhibitor like olaparib, just like Dr. Lang there. But I guess the one thing to keep in mind is that the objective response rate in the TALAPRO studies with combination enzalutamide talazoparib was higher. And with this patient who has lymphadenopathy that led to obstructive uropathy, now, a lot of those patients that get bilateral nephrostomy tubes, they may not be able to ever get them out. But if you have a chance to shrink those nodes and a possibility of getting them out, that might be a situation where I would consider the doublet there.
Yeah, it's interesting. It wasn't a choice at the time. Bridget, what would you tell his son? His son actually happens to be my patient too. Yeah, where should his son go? Because I don't know that a genetic counselor has much that they can say to him. If you saw this patient, how would you advise his son? What can they do?
Right. Well, so I think this circles back to your very first question around PSA, PSA screening. You also need to be thinking about at least breast exam screening, although, and then, do you actually do CTs or MRIs around pancreas? So, for him, this is one where you can have a very involved primary care doctor who may feel comfortable doing this monitoring. Otherwise, he might feel more comfortable seeing an oncologist sort of in a high risk environment where he can get advised for screening as data continues.
Yeah, I think it's a no data zone. He completely changed his diet. He exercises constantly. Like, I think he thinks he's going to get it, and he may not be wrong. He's the one who identified this first. He did, in fact, start on a single agent PARP inhibitor at the time, and he responded for a year. He progressed, and he really had a very brief response to chemotherapy. These were the choices we had at the time. So unfortunately, then he passed away. Let's just go to the third case, and then I think we'll send it back for some Q&A. This is a 52-year-old black male who presents with weight loss and 8 out of 10 pain in his low back. He has a PSA that's relatively low, 11, and a PSMA-PET with extensive bone and liver mets. No family history of cancer, some chronic medical issues, pretty young guy, starts on ADT. What would you offer next? Evan, what would you offer him next?
Yeah, this is unusual and a very aggressive situation with the liver metastases. So anytime I see liver metastases, I say it's never wrong to biopsy and get some tissue because liver metastases are more unusual and rare, and they tend to be more aggressive. I want to look for any neuroendocrine components, small cell cancer components. In this situation, probably not, but the PSA is not incredibly high at 11. There may be mixed components, some variant prostate cancers. I want to have that tissue to do next generation sequencing. I want tissue from the most aggressive location, and I do not want that to progress. So I'm going to start this patient on ADT as they've already started. I'm going to add doublet with an androgen receptor pathway inhibitor and triplet with chemotherapy. And really, I'm looking for, are there other targetable alterations that we should be going after there? So I want to get really aggressive in this situation.
Yeah, what if he had neuroendocrine features, Josh, in his liver biopsy? Would that change your approach?
So I would echo Evan if there's any evidence of neuroendocrine features, and I would also look at those other high-risk genomic mutations, not just HRR, DDR mutations, but also genes like P53, RB, PTEN. Those genetic mutations also associate with the development of liver metastases and are also associated with short duration of response to ADT or an ARPI. So completely agree with Evan in terms of the importance of triplet therapy, but then also very close monitoring after, because once he finishes the docetaxel, he'll continue on that combination ADT ARPI, but his risk of progression still remains very high. And this is where we really need to also think about platinum chemotherapies. So the data is not there for platinums as sort of a quadruplet, so to speak. But to the time of progression, if it's a rapid progression, especially in the liver, there can be very short windows of time to treat these men. So we don't want to miss that opportunity. So they need to be monitored very closely while they're on their ARPI. I don't rely on PSA alone, especially in these settings where the PSA is low relative to the burden of disease. I'm doing scans every 2 or 3 months for these gentlemen. And then if I see evidence of progression, I'm going to think about that next line chemotherapy, considering a platinum. But even more importantly, what are those other agents and clinical trials that are out there too? Because as you mentioned, William, whether it's, the BiTEs, some of the new radioligand therapies, a lot of new exciting options for men with these very aggressive cancers, and I would get him right to a clinical trial.
That makes a lot of sense. And in fact, he did get docetaxel and Abby. His PSA dropped to 1.5 and his liver lesions did improve, but in a short time he progressed, increasing PSA and pain. The liver lesions are increasing in size, and he has a PET scan, which is equivocal in the liver and moderate in the bone. So, Bridget, would you offer him, a LU177, or what's the general take on the value of a PSMA-directed theranostic in a patient like this?
Yeah, no, so I have two thoughts on him. And the first is actually with his pain. Very early on, I'd offer him palliative radiation to the lesions in the spine. And that can be a very quick course. That can be, one treatment to 2 weeks, and that way we can get him onto his therapy and hopefully help with the pain. And I also very much would not have recommended Pluvicto in the initial setting because of how aggressive this disease is. And yes, while absolutely Pluvicto or lutetium PSMA therapy has really opened up, I still think chemotherapy is a very important choice the more aggressive the cancer becomes. In this situation, he's received chemotherapy, and so now I think the lutetium 617 PSMA therapy certainly is a good option to give him another, something a little bit different. It is system-wide. It does bone and liver lesions, and definitely worth a try.
All right, thank you. That was really a great conversation. I know we have some questions. Lucas, do you think we have some time to address a few of the questions? Do you wanna ask?
I think that we have a very quick 1-minute lightning round for this question that did come in. It's regarding PARP inhibitors and their potential toxicities and subsequent dose reductions. How do patients work through those considerations with their doctors who are overwhelmed and too busy for good communication? How do we guide these patients appropriately to a decision about a treatment that might have some significant side effects?
Josh, do you want to take the toxicity profile of PARPs?
Sure. First off, I'm never too busy for my patients. This is something where all of our patients deserve the time and attention, especially when we're getting a therapy that can be very effective, but does have side effects that need to be managed. So we're never too busy. You deserve the time and demand the time. In terms of managing the side effects of PARP inhibitors, we know that the dose that many of them were started at, that anywhere from 40 to 50% of patients require a dose reduction. So it's very common. And early changes in blood counts, with anemia being one of the more common causes of dose reduction with PARP inhibitors, watch that closely. It's something I do in my clinic where, at the very least, getting blood counts every month. Sometimes, in some situations, we're doing them every 2 weeks. And if we're seeing that toxicity emerge, intervene early. Don't wait for it to be something that causes clinical symptoms, because that's when we can really intervene early with a dose reduction. And oftentimes, if we find it soon enough, we can avoid blood transfusions. But again, if there's a really rapid drop, people are symptomatic, don't suffer at home. Don't try to tough it out. Call us. It's what we're here for. We get lonely. So when in doubt, give us a call, okay? Because we can do a blood transfusion. We can get things started. We can reduce the dose, and people will feel better in just a short number of days or short number of weeks. So these should be very straightforward to manage.
Thank you. Lucas, back to you. I think I know we're running low on time, so thank you to the panelists. Really appreciate your great answers.
Yes, thank you, everybody. And no worries, this was a fantastic discussion. So happy to spend a few extra minutes on that. We should be able to get through the rest of this in plenty of time. So I'll ask Naya to put the post poll up. We're going to ask you to work through this poll as I go through the rest of the slides here, just to make sure that we're respectful of everybody's time. But hope you really enjoyed that, because I certainly did. So thank you very much to all of our panelists and Dr. O for leading the discussion. This was a great session. So as you're taking that poll, just want to let you know about a couple of other opportunities for learning through ACS. We are starting a new cohort for prostate cancer screening, ECHO. The ECHO is a peer-to-peer mentoring forum, really, where anyone who is involved in primary care handling PSA testing and specialty referrals, we're inviting you to come to this open ECHO, register through this link at the QR code here. I'm going to move past this pretty quickly. We will make these slides available after the fact through our website, and we'll reach out to all registered attendees to provide you with links to the recording and the slides. So this will be findable later. We also have several other ECHO programs starting alongside that screening ECHO. These are not prostate specific programs necessarily, but they are very, very relevant to patient outcomes and key considerations in screening and management of cancers. So please consider signing up for these programs as well if they are of interest to you. Lastly, we invite you to stay in touch with us. We are the roundtable is going to be having a lot more programming around advanced prostate cancer. We actually are hosting a summit in just a few short weeks here to discuss some of the critical issues facing advanced prostate cancer patients and specialty populations within the advanced prostate cancer community, things like preserving bone and cardiac health. And so we're going to be putting together a slate of programming around those considerations going forward. So please do join us via our website, our LinkedIn account. X account doesn't get much love really anymore, but we do also have a newsletter that you can sign up for to stay in touch with us and make sure you're getting all of our announcements. So just wanted to say another huge thank you to everyone for joining us today. Even bigger thank you to our panelists and Dr. O, our moderator. Thanks for joining us. Have a great rest of your day, and we hope we'll see you next time. Thanks so much.